Good afternoon. Thank you all so much for joining us this afternoon. We're about to start momentarily. I'd like to ask if you would please turn off all cell phones. Thank you so much.
Thank you, Sanday. I could have done that too. You know, they'd listen to me. They wouldn't listen to me. I'm Michael Erickson. I'm Dean of the School of Public Health at Georgia State University, and we're extremely excited about today's event, and thank you for coming. We had extended invitations broadly throughout the community, and we were pleased as we were reviewing the attendance sheet that 60% of the attendees are from outside Georgia State. So we're very proud and pleased and want to reach out to the broader public health community in Atlanta and continue to do events like this, particularly for this one, which is a very special event to honor the contributions of two outstanding individuals who are part of our community and have made an indelible mark on health equity during their careers. You'll hear more about each of them in a little bit, but this is really the first of an ongoing series of lectures on health equity that we will be holding at Georgia State with the support of the Healthcare Georgia Foundation. And we'll go into more details, and you'll read more about both the School of Public Health and the foundation in your brochure. What we'd like to do is to kick off this inaugural lecture series with a short video that comments on the contributions that Marshall Kreuter and Martha Katz have made during their careers towards health equity and public health. And then I'll come back up on the stage and introduce our keynote speaker for today. Our public health program at Georgia State is really focused on applied public health and urban health. So urban areas often have the greatest disparities, and we try to do real work in the communities to understand better and address these health disparities. Marshall has been a real leader in this regard. He has opened the door to our students and our faculty about community-based affecting communities in order to understand how best to address these health disparities and achieve greater health equity.
Martha and Marshall are special people. They are committed to social equity, committed to public health, bring a mixture of skills between them to it. In fact, you could have a school of public health that was largely based on the faculty of Martha Katz and Marshall Kreuter and would cover most important subjects in it. It tremendously.
I began my career as a school teacher almost 50 years ago, 45 years ago. And I have always been committed to trying to create experiences that will help students learn and see the value of the content that they're dealing with. When I went to Georgia State to join what was then the Institute of Public Health, which is now the School of Public Health, I began doing that. bias for experiences probably led me into my own interest, which is community-based participatory research. I'm very grateful to Michael Erickson and his colleagues for providing support for a project that we did at Georgia State called Accountable Communities Healthy Together. It was a research project funded by the National Association of Minority Health. And we went into urban Atlanta and used the same principles that we were talking about, community engagement, listening to them, try to address the health problems that they had. And it's a really good example of understanding the importance of listening to people.
I think the process is great. Whenever you have opportunities to engage community and to defining what the issues are that confront the community. I think one of the things that we as practitioners have to learn how to do is to listen to community. A lot of times we come in and we understand the process and we so quick on the process that we don't really hear what the community is saying to us. And one of the powerful things that I've learned in my organizing is that the most powerful thing that we do is listen.
Some 30 years ago, I had the opportunity to meet Marsh, who was a professor in health education at the University of Utah. And what I recall about his experience there, and my experience with him, was the training and education opportunities that he afforded students. One of those, a very unique experience, which I would call immersion learning, where he would put students in real-world situations so that they would understand and appreciate the circumstances of the underserved, the institutionalized, the marginalized. And so from the very beginning, one could see the DNA in Marsh that spoke to social justice issues. Martha as well has a distinguished career in this area, and specifically in terms of her work in health policy. We can look around the state and find a number of health policy organizations that did not exist. But when she came to the foundation, she helped the foundation incubate a number of nonprofits, health policy organizations that specifically addressed health disparities and health inequities.
My four grandparents were all immigrants. They came to this country with very little. But somehow or other, my grandmothers and my mom every Friday managed to be able to put a little something in the charity box. So it was very clear to us when we were small children there were haves and have-nots in this world, and that we were supposed to do something about it. That, of course, spills over into what you do as a person in your career. I've had the pleasure of working with both Healthcare Georgia Foundation and GHU. I got to be an early staff member at the foundation. I got to chair the board of advisors for the then very new School of Public Health, and it was a public health program. Now it's grown. And as a member of the Georgia Health Foundation Board, I get a chance to work with both of them as a colleague from that perspective. So that gives me sort of a nice picture of both organizations. They're very different because one's a private foundation and the other is a university. And they have different missions, but they have a lot in common. Both organizations have a real commitment to health equity. They know we've not achieved our goals in public health everybody, and especially the most vulnerable.
Martha was our first chairman of the board of advisors for the School of Public Health. And even today, this award that we're highlighting the careers of Marshall and Martha is the idea of Gary Nelson and the Healthcare Foundation. Without their vision, support, and commitment, we wouldn't be here today. Proud that the colleagues that I've worked with over the years have made an effort to help other folks, and kind of that's why we're here, to help one another. And if this in any way benefits students, causes people to think about the importance of health equity, making health for all really something important, keeps it at the top of their mind.
I'm sure having a named lecture series for them both delights them and they're honored by it. And I suspect they're both a little embarrassed by it all too, because they're so humble. Well, tough luck, Mark. You gotta enjoy every second.
Good afternoon. I'm Gary Nelson, president of the Healthcare Georgia Foundation. I'm so glad you've joined us. At the core of the mission of Healthcare Georgia Foundation is a deep commitment to health equity. And that commitment guides us in the communities that we work in and the people that we work with, including this terrific School of Public Health. It's a pleasure. It's really a privilege and an honor to sponsor this lecture that pays tribute to the careers of Marshall Kreuter and Martha Katz, both of whom have made so many contributions through teaching, service, and research that not only exposed health equities, but addressed them as well. It goes without saying that throughout this world, internationally as well as nationally, in the state and in this community, there are public health professionals that owe a great debt of gratitude to both Marshall and Martha. And on behalf of all of them, thank you. Michael?
As you can imagine, having an event like this is not simple. It needs support and planning and time, and we had a planning committee to help us establish this lecture series, which this is the inaugural lecture. And on the topic of health equity, the planning committee chose a speaker, and their first choice was Ichiro Kawachi. And we contacted Professor Kawachi at Harvard and said told them what we were doing and that we were looking for an outstanding speaker. And he was the first choice of the planning committee. And here were some possible dates. And he got back to us and said he couldn't make it, that he had to teach on those days, and teaching was first priority, and he wouldn't miss his class. So we felt he was blowing us off, of course. He said, Marshall who and Martha who? But we said, let's go back and say, is there a date that would work for you? And he said, well, April 25th would be perfect. So we arranged it, we scheduled him, and here we are today. There were some lessons from that, not to give up. Go for your first choice, and you can make a difference when you do that. Many of you are well aware of Dr. Kawachi's work. He really needs no introduction. He's the first choice and the most fitting speaker for this inaugural lecture on health equity. He's a professor of social epidemiology and chair of the Department of Social and Behavioral Sciences at the Harvard School of Public Health. He holds both a medical degree and a PhD in epidemiology. He's published over 400 articles on the social and economic determinants of population health and has co-edited a textbook on social epidemiology. Those of you who are in the academy can get some perspective on what 400 articles really mean, which is a lofty number. He is an elected member of the Institute of Medicine and the U.S. National Academy of Sciences. And please join me in giving a warm welcome for Ichiro Kawachi.
Thank you very much, and what an honor it is to be here to address the inaugural Kreuter Katz lecture. So I'm going to speak about social capital and health for the next 45 minutes. As some of you may already know, Marshall was an early advocate and proponent of the concept of social capital and its promise as applied to community health interventions. So I feel like I'm lecturing at the feet of a master here, and let's see if I can give an adequate account of myself. Marshall said as early as 2002 that he posed the question, is social capital a sentimental extension of Alexis de Tocqueville's perception of American democracy, or might it represent a piece of a complex puzzle that, properly understood, would aid our understanding of community-based strategies? And so that's That's the question that, the challenge that he's laid down for us. And in my outline of the next 45 minutes, I propose to proceed as follows. It's impossible to talk about social capital without first defining what that is. It's a contentious topic, so I'm going to attempt a definition. Then I'm going to dive into some causal inference, because everyone wants to know whether if you change social capital, can you change public health? And then I'm going to finish by describing the application of social capital to disaster resilience. There's one place where the concept has found tremendous leverage, in my opinion. So let's begin with definition. My definition harks back to sociologists like Bourdieu and James Coleman, who said we can define social capital as resources derived from membership in social networks. There's nothing complicated about social capital. I mean, it's just we recognize there are lots of different kinds of capital, including financial capital, human capital. Well, social capital is just that form of capital or resources that we derive from social relationships. And we can analyze it either both as an attribute of individuals as well as a characteristic of the group, in which case sometimes people use the term social cohesion. Now, the issue about all the controversy and debate about social capital, for those of you who have been following it, is that it isn't as simple as I'm showing it here. There are some people, among them very eminent people like Kenneth Arrow, who is a Nobel Prize winning economist, who opine that social capital is not capital, at least to an economist. He said, because capital has two characteristics. Number one, its creation entails some form of sacrifice of present consumption for future benefit. And secondly, because capital enhances the productivity of other factors of production. Now, I think we would all agree that social capital, resources derived from networks, satisfies B, but he said it doesn't really satisfy A, because when we hang out with friends, we're not doing it in order to obtain future gain. At least most of us don't, But I think there's a way around this. Far be it for me, the lowly social epidemiologists argue against the Nobel Prize winner in economics, but it seems to me that there's some kinds of social investment that we make, which does entail some sort of sacrifice of our time. Economists agree that time is a limited resource, and when we participate in social activities, or especially when we volunteer for community activities, it does seem to me that that element of it satisfies condition A. It's entailing a sacrifice on the people of present consumption of their time for future benefit. So I think one can argue whether Kenneth Arrow was right or not. Now, the second part of the definition is that some people argue that social capital is not social. So if it's not social and it's not capital, what the heck is it? I mean, it's a little bit like how people used to talk about the Holy Roman Empire. It was neither holy nor Roman. And Voltaire added, well, it's not an empire either. Well, the argument there is that, I've heard is that, because the benefits of reciprocity exchange in a social network are limited to members of that network, it really doesn't have that social characteristic. But I argue against that as well. I think there are ways in which social networks can have spillover effects on the rest of society, as well as people who don't even belong to networks. That's my reason for saying there's such a thing as social capital. Now, if you just go back to thinking about how networks help people, if you think about yourself, let's say you're the person in the middle and you're surrounded by a network of friends, the kinds of resources that I'm talking about that get exchanged in social networks include access to valuable information. Sometimes that information is helpful for advancing health. We certainly can turn to our friends for instrumental assistance, cash loans to go to a clinic or labor in kind. And of course, there's very important social reinforcement that we are supported by our friends, and our behavior is reinforced, whether that's the decision to stop smoking or to start exercising or whatever. So these kinds of benefits are obvious to everyone. And I guess the critique is that if we just if the resources are just kept within this intimate network, then there's nothing social about it. It's just your private social networks. But I think it goes further than that. I think there are some emergent properties of social networks. If we expand out to the group of people whom we may not even be personally familiar with, there are some emergent properties as a result of belonging to that group. So if you here I've just I borrowed a picture on this individual's extended social network. And if you look at this person circled in red, some of those people out on the peripheries of that network, that person is not immediately familiar with. They don't know that person. If they did, I would have drawn an additional arrow connecting them. But in this case, you can see that people on the outer peripheries may not be even familiar with that person, and yet network topography, network characteristics predict that some things, depending on what features of that network, some things will emerge, such as social contagion of healthy as well as sometimes unhealthy behavior. That group is able to exercise informal social control for the collective good. That group is more able to exercise collective action, something we call collective efficacy. And I'm going to come back to examples of that. Let's begin first with social contagion, though. In this diagram, I've shown just one person in the blue in the corner smoking. And social contagion is the idea that if you belong to a network in which there's someone smoking in your network, you may be influenced by that person's behavior, even though you may not be familiar with them. You may not have face-to-face contact or any knowledge of that person, but because of this network structure, you may be influenced by their behavior. That's a network property. That's the social part of social capital. Specifically, the claim is made that in the case of cigarette smoking or smoking cessation, that influence can spread up to 3 degrees of relationships. So in that red hoop that I've drawn here, people who are 3 degrees separated from that smoking individual on the right-hand bottom will be measurably impacted by that person's behavior if they decide to stop smoking or to start smoking. And that claim, by the way, is not mine. It's the claim made by the famous Kreuter and Fowler study in the New England Journal of Medicine, in which these authors conducted a nearly 4-decade follow-up of the Framingham Heart study, in which they were able to map people's social networks over time and to map the contagion of behavior. And it just, by pure chance in the Framingham study, every time individuals came back for a routine exam, they asked them, in case we lose touch with you, can you name 5 people that we may get in touch with so that we can find out where you are? And because of Framingham, which is a close-knit community outside Boston, because of the nature of Framingham, it happened that quite a few of those people who were named also happened to be taking part in the study. So they're able to do the sociometric mapping and then to trace the spread of behavior, both good and bad, throughout the network over a 4-decade period. And so you've all heard the result that obesity is contagious. When we say obesity epidemic, we really mean that it has some epidemic properties. But in this case of smoking, here's what the Framingham network analysis looks like. It's divided into 1971 at the beginning of follow-up and 3 decades later in 2000. Now this diagram is showing each circle as an individual, and every time there's an edge or a line between 2 circles, it means that those people said they know each other. And it's color-coded so that in the left-hand side, yellow means that someone was a smoker, and when they stop smoking, they turn green. And one can see from the, I think you can see this by just squinting a little bit, the left-hand diagram shows that it looks predominantly yellowish, as if the whole of the Framingham community was drenched in nicotine juice or something, which describes how America looked in 1971. The majority were smokers. But as people give up smoking, it turns green, predominantly green by 2000. And what Kreuter Katz and Fowler did is to model the spread of smoking cessation according to network connection. And one of the conclusions that they came to was that, number one, if you're still smoking in 2000, you tend to get pushed out toward the periphery of networks. So you see the yellow people remaining on the right-hand side. They tend to be pushed out toward the edge of the network. You tend to be ostracized by your friends. The second conclusion is that in that right-hand and left-hand diagram, if you are connected up to 3 degrees of separation from anybody who's smoking, you yourself have a detectable increased risk of either stopping or starting. That's a remarkable result. And they're saying this, and that's the network property. Smoking cessation is apparently socially contagious. It appears to obey what they call the 3 degrees of separation rule. So you're at risk if your immediate friend smokes, but you're also at risk if your friend's friend smoke, and you're at risk if your friend's friend's friend smokes. Now, the amazing thing about that conclusion when we think about it is that it's saying we may be influenced in our daily lives by the behaviors of people we don't even know, because most of us, by definition, know our friends. There's a good chance that you probably know your friend's friends, right? But I would say that most of us have no idea who are our friends' friends' friends. And yet this result is saying that if your friend's friend's friend stop smoking somewhere in your network, eventually that effect will wash back on you, so that if you're smoking, you will also be measurably influenced to give up. That's the finding that they made. Now, I'm not going to say, because it's someone else's study, I'm going to start talking about my stuff now. I'll just say that there are a couple of caveats about what I've said so far. Of course, social capital is agnostic with respect to whether the effects are good for health or bad for health. It's like any form of capital. Financial capital, I can use that to oppress people or help people. So it's agnostic with respect to whether we're talking about health promotion or health destruction. So in the same Framingham study, as smoking cessation spreads through social networks, so does obesity. Maybe they move together because you stop smoking, you gain weight. They also, Kreuter Katz also showed that the spread of happiness occurs through networks, as does the spread of loneliness and depression. So it can cut both ways. If your network is predominantly blue, well then you'll eventually become blue yourself. That's what we call the dark side of social capital. I always have to warn everybody, social capital doesn't always look toward health promotion. And of course, I don't have time to explain all this, but causality is also disputed. Papers by Cohen Cole and Jason Fletcher, Russell Lyons and others who say that the methodology doesn't quite add up to a conclusive demonstration of proof of causality. Now, the measurement of I'm going to talk about causality in just a moment, but the measurement of social cohesion in public health is through survey items such as asking people about their perception of whether the group that they belong to is more able to undertake collective action. We call that collective efficacy. Are they able to exercise control over other members' behavior? How much do you trust members in your network or in your community? Are there norms of mutual assistance, reciprocity? And is it a vibrant kind of network where people are volunteering and socially participating? I want to say a word about social participation. There's tremendous social participation is a part of social capital, because as people participate, they're more likely to build trust, and you need trust of other people in order to exchange favors, and those things also add up to the group's ability to undertake collective action and to exercise formal control. So they're all kind of interconnected, but there's a lot of skepticism about whether social participation is causally related to health. And I'm going to give 2 examples. A lot of my research now is conducted in Japan, so I'm going to mention the research of a bunch of my former fellows and younger colleagues. This is one done by Satoru Kanamori, which is based on a study of social participation and the prevention of disability among older Japanese individuals. We had access to a cohort study of almost 13,000 subjects aged over 65 years or older who were free of disability at baseline, and then we followed them up for a period of 4 years. And we're looking at whether social participation, particularly participation in a sports organization, is related to their risk of developing functional disability as determined by a physician medical examination. Now, sports organizations, of which there are several types in Japanese communities, I think sports organizations are in some ways one of the backbones of Japanese social cohesion. And the question we asked was, what's more important for the prevention of disability? Is it the fact that people are regularly exercising or the fact that they are socially participating? Let's compare these head to head. It's like when we say, do people live longer when they belong to clubs because they're healthy and that's why they participated? Or is it the participation itself which encourages health? Now, the kinds of seniors sports organizations that people belong to include gateball, petanque, walking groups, and it's not really proper golf, but sort of a miniaturized version of it. So they come together, these people in the neighborhood, to participate in these kinds of organizations. Now, the trick that we did was we developed a 2x2 matrix of people who said they participated in sports organizations and cross-classified according to whether they actually exercised or not. So some people are physically active in their daily life, and other people are sedentary, meaning they did less than they did no leisure time physical activity in their lives. That's the definition of sedentarism. Now, you may find it rather interesting, but you see on the top row, if you are physically active and you belong to one of these sports groups, we say you're an active participant. But there's some people who are physically active but don't belong to an organization. You call those lone exercisers. You're exercising when you're sort of doing it by yourself, perhaps in your basement treadmill or something. Then we have on the bottom row people who are sedentary, and yet they say they belong to a sports organization. How do they do that? What is that? What are people doing? So I'm not quite sure. We think they are participating, but participating as the club treasurer or the club observer or something. They say they belong to a sports organization, but they're not participating. So that's a very interesting group. And then, of course, there are the people who are sedentary and don't belong to a sport. So they're both alone and they don't exercise. So remember, this is a 4-year follow-up study. This is an adjusted hazards ratio of incident functional disability. Not surprisingly, people who both belong to a club and are physically active are the healthiest, and we use them as the reference group. And then when we look at people who don't exercise at all, but they don't exercise and they don't belong to an organization, sure enough, they're at about 60% increased risk of developing disability. We already knew that. That's, being disconnected and sedentary is bad for health. But the really surprising thing is this, which is that if you're a lone exerciser, it's not very good. It's not very good to people who exercise and belong to clubs. If you don't belong to a club but you still work out on your treadmill, you're still at about 30% increased risk of developing disability compared to someone who both belongs and who exercises. People who the bottom one is these treasurers who belong to clubs and they don't exercise at all. Those people have no more increased risk of developing disability compared to those who are actively participating. So, the answer to that question I posed, is it the exercise or is it the participation? It's the participation, It's the participation that prevents disability. It's not the fact that they're exercising, If they exercise in a sports club, that may look good, but it's really the participation that's the active ingredient. That's one, I'm deliberately overstating the case because, of course, no epidemiologist would accept what I just said is cause or effect. We really, although actually I believe it, it's a hypothesis of mine. I think, why is it that drinking green tea is good for longevity? It's not the whatever is catechin in the tea. It's really the social participation. As a social epidemiologist, that's my hypothesis, and no one's yet to disprove it. But anyway, the causal question is this one, which is, do we really think that exercise improves health, reduces mortality, reduces functional disability? And of course, the two immediate alternative hypotheses that we have to think about is reverse causation. Only healthy people participate in clubs. If you're housebound and disabled, you're not going to come out and join a club, even as a cheerleader. That's number one. The second is confounding. Common prior causes, including unobserved things like congeniality, temperament, personality, genetics, anything, anyone with a cocktail napkin could generate a long list of confounders that could explain why these two things seem to be associated. So what the epidemiologist has to do is to do a randomized trial. You have to go back to this experimental tradition. You have to take a group of people, and on the toss of a coin, you make half of them begin to participate, the other half you make them stay at home. Kind of hard to do because might take a while to get that through the IRB. So the nearest thing, and often in social epidemiology, we do have these situations where our treatment or our exposure is hard to randomize. So the one solution that we can think of is to think of a near experiment, a kind of a natural experiment that we can use to leverage the association between social participation and good health. And in our world of economics and epidemiology, we call these instruments. The variables that of the type Z are called instrumental variables. They're natural experiments that we can look for in the data set to try to identify the causal effect of social participation on good health. It's exactly like as if you'd done a coin toss. A coin toss is a perfect instrument because according to whether it comes out heads or tails, it completely assigns the individual to treatment without directly affecting the health outcome. And in so doing, it cuts the linkage between the confounding variable and the relationship of interest. So the idea is we want to find an instrument that acts like a coin toss. And here's my second Japanese study done by Ichiro, who's a keen fisherman. And in this study, we took a study which was based on a community-based intervention to encourage social participation among seniors. It was based on a cohort study that was ongoing, and the study is called the Takatoyo Intervention Study. It's conducted in a town that's just south of Nagoya, which is the third largest city in Japan. Nagoya is the home of Toyota Motors, for example. And the instrument we found was this one, which is that in 2007, the municipal authorities decided to launch a campaign to promote healthy aging among its citizens. And the intervention consisted of the opening of community centers for seniors, where seniors could gather, which the Japanese call salons. I don't know why, but they're called salons. And it just happened. It just happened to be that some of these town residents also happened to be participating in an ongoing cohort study called the Aichi Gerontological Evaluation Study. So, we're doing this cohort follow-up, and in the middle of it, the town decides to open a bunch of senior centers called salons. So that's like an exogenous, it's like an experiment. We're arguing it's as good as having a natural experiment. This is what these salon programs look like. You go inside, all these seniors are gathered together. They don't necessarily know each other, but they're competing, doing poetry, composition, playing bingo. Bingo seems to be common throughout the world, in terms of things that happen in senior centers. Now, here's the naive comparison of people who participated versus those who did not participate in the salon activities in that cohort study. Remember, we had this cohort study where we can ask people, did you participate in your salon or not? And a bunch of people said they did, some of them said they didn't. And what we see here, right there in the baseline, in 2006 is that those who participated were already healthier at baseline. That's the reverse causation bias. Is why no epidemiologist would trust any result that showed that people who participate are healthier, is because that's why they participated. But you see that over a 2-year follow-up, those slopes differ. Those who participated had a improved rating on their self-rated health. And so the instrument is this. We said, let's use the distance between each individual's home address and the nearest salon which happened to open near them. That's like a coin toss. It's like saying, what we're saying is, if you were living in different parts of Takatoyo City, and just by pure chance, the authority decided to open a senior center close to where you're living, then if it happens to be close to where you're living, then all other things equal, you're more likely to participate. If you're living further away, you're less likely to participate. That's an instrument, because the distance itself should not have any bearing on your self-rated health. Where if it does, it's only through the fact that you participated. That's the sort of argument. It's like in instruments, when economists tried to figure out the health benefits of angiography, before the trials became available, they used distance to the nearest angiography-capable hospital as an instrument. If you had your heart attack and you're living closer to an angiography-capable hospital, you're more likely to receive it. And that difference we can leverage to estimate the causal effect of angiography on survival after coronary. And that's exactly the idea we're using. This is an example of where the participants were and where were the sites, 3 of them. I guess by 2012 they'd opened 10 different sites. And here are the results. First of all, the further away you live from a salon, the less likely you are to participate in the activities of that salon. It's just saying that the instrument works as we intended. Distance is like a coin toss. If you're further away, you're less likely to participate. If you're closer, you do participate. All right. Maybe I should skip this here. This is it's just saying that all the saying is that you plug the instrument into a 2-stage procedure in order to recover the causal effect. And I'll walk you through it. So it's done in 2 stages. In the first stage, you're trying to figure out, does the instrument actually work? And the outcome here is the probability of whether someone participated in the salon. And it's showing that, first of all, we control for baseline self-rated health on a Z-score, and that's positively significant, meaning the healthier you were at baseline, the more likely you are to participate. That's the reverse causation part of it. But the inverse of distance is also significantly associated. The further away you are, the less likely you are to participate. That's what this is saying, is significant. So the instrument is working, it's relevant, and in the second stage, you plug in the variation in participation into a second equation, which is predicting your health in 2008. And this is showing that your health at baseline predicts your health at follow-up. But in addition to that, after instrumenting salon participation, there's a significant positive correlation. So it's saying that basically after you do this fancy schmancy econometric technique, those people who participate more tend to end up with better health in 2 years later. It's a more believable estimation than looking at ordinary least squares regression. Now, some of you are wondering, maybe why is it that something as innocuous as playing bingo and doing poetry composition should have an impact on the health of the elderly? I mean, if only life was so simple. And I think one of the reasons why this worked in Japan comes from a cross-cultural comparison of the effects of marriage on health. This is where, to be a good social epidemiologist, you also have to be a bit of a cultural anthropologist. And so the cultural difference between the meaning of marriage in these 2 countries. Now, you all know that marriage is good for longevity. People who that's why I'm married. But people who are never married, who get divorced or widowed, tend to have an increase in their mortality. It's one of the most robust effects in social epidemiology. And so robust, in fact, that someone did a meta-analysis of over 50 studies involving 250,000 elderly subjects, and they showed that relative to those who are unmarried, that is, they were never married, widowed, or divorced, those who were married have about an 11% significant reduction in their mortality hazard. And in this paper, they said there's no gender difference. Men and women benefit about equally from being married compared to not being married. This is the kind of chart that we show for meta-analysis, where we try to summarize all the results. And what we're looking for is that the point estimate should line up on the left-hand side of the null value. These are the results for men, and I just highlighted the pooled results, which says 0.88. That means that if you pool all the studies together and summarize them, married men are at about 12% reduced risk of dying compared to married women, unmarried men, for whatever reason. And when we look at the same result summarizing for women, we see that the hazard is 0.90. So we say 0.90 versus 0.88, that's not significantly different from each other. They both, men and women, benefit to about the same extent. That's, in round numbers, it's about a 10% mortality advantage compared to those who are unmarried. However, one thing when I was looking at this paper that really stuck out for me was that, remember, you're looking for studies that line up to the left-hand side of the null value. There's one study that stands out, which is on the right-hand side, meaning marriage in this case is actually toxic for women. And I was very struck by the author's name, Nagata, which sounds Japanese to me, so I looked her up. And sure enough, she is Japanese. It's a Japanese study. In Japan, the one study that made it to this meta-analysis shows that in a 7-year follow-up of elderly men and women who were married, widowhood was, first of all, not significantly associated with mortality in men, so Japanese men don't seem to benefit. On the other hand, widowhood was significantly inversely associated with mortality in women, meaning married women die faster, in Japan. As a matter of fact, there's a significant decreased risk of mortality for women who are widowed for 3 years or more. Get rid of the husband, they live longer, And that's a cultural difference. And there are other studies, showing that older married Japanese women, for example, report higher prevalence of bad health. You see, this is the prevalence of fair or poor health compared to never married and widowed and divorced. It's the married women, elderly women, who report by far the worst levels of health, which is the opposite pattern to what is found in many Western countries. And I think that's where the cultural anthropology comes in. There's a comparison between what happens to couples after retirement in the United States, the typical, what AARP would have us believe is that people retire and then they go off bicycling into the sunset. At least that's what I'm planning to do. But in Japan, it's quite different. In Japan, it's very different because men and women in Japan spend very different lives during their working lives. The men are over-involved in work. Women, for the most part, do not participate in the labor market. They stay at home. So when the two lives come together after retirement, their worlds collide. And that gives rise, in Japan, to the so-called husband-at-home stress syndrome. Those of you who know how to read Japanese, this says, shujin zaitaku stress shokogu. And this 60% is a major problem. Most of the divorces and problems happen after retirement in Japan. And this is a true picture I pulled off the internet, a sad picture of all these men who've been thrown out of their homes after retirement because their wives won't let them be there, So they spend the whole day on a park bench, somewhere in central Shinjuku. So that's the cultural anthropology element of it. And in fact, you can keep going on this theme. In Japan, there's a common thing called a saying called the Nure ochiba phenomenon, which translates as the dead leaves that stick to one's soul, and you can't rub it off. That's how the women describe their husbands. It's like these rotted leaves that you pick up on the soles of your feet and you can't get rid of them. And the Washimoto means Me Too tribe, which I think is referring to the idea that when the woman decides to go shopping, the husband who suddenly has nothing left to do says, I want to come too. And she doesn't want her husband coming with her. And the worst usage of all is sodaigumi, which means oversized trash. Enough said, I'm not going to translate that one. So that's why I think in Japan, Salon programs are a very effective intervention for preventing disability and providing social capital. They provide a place. The Japanese have this concept of ba to mean a place where people feel they belong and they can congregate without having to spend the whole day in a park bench somewhere. So that's one of the reasons. Okay, so I think disaster resilience is the last and most important emerging application of social cohesion. As I mentioned, we said cohesion is measured by all these things: informal control, collective efficacy, trust, and so forth. And we know that these things come out especially to the fore in the aftermath of disaster. There's nothing like disaster to test the mettle of a community. And so informal control, for example, comes out when there's prevention of looting after disaster, because community residents look out to make sure that these things don't happen. And in contrast, every time there's a disaster anywhere, one of the first things that happens is that people have to be on guard for looting. And in the 2011 Tohoku tsunami, everyone, the media, the one thing that media picked up was that the Japanese ran out of provisions, in the affected areas. But here it is, everybody decided to line up for half a day to go to the convenience store to obtain water rather than to go directly to obtain it for themselves. Collective efficacy is the ability of the community to mobilize, for example, organizing disaster efforts and then the cleanup and so forth. There's a rather interesting book by Purdue professor Dan Aldrich, which describes the importance of social capital for post-disaster resilience. And he says there are at least 3 mechanisms we can think of why community social cohesion matters for disaster response. One is because when you have a cohesive community, residents provide informal insurance for each other by helping them out through exchange of material resources. Cohesive communities are also more effective at voicing their concerns to authorities for disaster relief. That's the collective efficacy part of it. I guess this is sort of playing on L. Hirschman's voice, exit, and loyalty. Socially cohesive communities also raise the cost of exiting that community. Many communities suffer from, in terms of reconstruction, because people leave and then never come back. But if you have roots in the community, they're more likely to come back and to help in order to reconstruct. So that the third and final Japanese study is directly one related to the 2011 earthquake and tsunami. As you may recall, there's a magnitude 9 earthquake, which led to about 18,000 people dead or missing, and over 340,000 people who were displaced. Now, the reason why I'm doing the study is because in 2010, my colleagues and I happened to establish a baseline for a nationwide cohort study in which we're going to study social cohesion and functional disability. We managed to have about 112,000 people enrolled throughout the Japanese mainland. And one of the field sites, just by pure chance, happened to be the town of Iwanuma. Iwanuma was, in turn, was 80 kilometers west of the epicenter of the earthquake. And I think this is one of the few instances in which in disaster research we have managed to characterize the social capital and health of a locality prior to earthquake and tsunami. And on the day of the tsunami and earthquake, Iwanuma, here it is being attacked by the tsunami. If you think about this on an aerial scale, here's the Pacific Ocean. The red line shows the extent to which the tsunami reached inland, and the blue circles represent all the people who responded to our survey in 2010. That is 7 months before the earthquake and tsunami. So we convinced the NIH that this was a unique natural experiment, that we could go back and study the effects of social cohesion on disaster resilience and recovery. And so it just happened to coincide with the NIA program announcement, which said we want to encourage research on the functioning of the elderly after disaster. So we sent in an application. We said we want to study whether residents who live in communities with higher levels of social capital manage to experience a slower decline in functional independence afterwards. And we happened to have from baseline survey measures of civic participation, informal socializing, and trust. And our outcome is whether 3-4 years later, people are more likely to develop medically diagnosed disability or decline in functional status according to the characteristics of the community in which they lived. So this is my recent R01 project. The town of Iwanuma has about 44,000 residents. We know that 150 of them have lost their lives as a result of the disaster. There's a 0.3% mortality rate. And roughly 5,500 were evacuated because their homes were partially or totally destroyed. We set off the mailed baseline survey back in 2010, before the earthquake, to all of the residents over the age of 65 living in that town. And it was not atypical of community surveys. We got a response rate of 59%. In the follow-up survey we've been conducting, we just finished last month, and we managed to trace every resident in the town, 100% through the Japanese residential registration system. We're told by the municipal authorities that there's one resident that they can't account, they don't know where they went to, but it's 100% follow-up rate. So you may ask, why should social cohesion have anything to do with the prevention of functional disability? And we have some clues. I think it comes from, basically this idea comes from a qualitative study that one of our fellows has done. We managed to contact residents who were evacuated to temporary shelters, and as happens after disaster, the evacuation of residents into temporary housing happens along two different ways. In one form, residents get they get assigned to temporary shelters based on a random lottery. They sort of say, these shelters have become available. Who wants to move into them? And in some villages, they said we'll draw a lottery, and those whose lucky numbers come up will go in first. In other villages, they basically said no one's moving until you can house us all together. So in those villages, they moved by group relocation, which had the benefit of preserving existing local ties. And that's rather important. It turns out that people who moved in by lottery may have thought themselves lucky because they got there first, but in fact it tended to pull them out of their existing social ties. And if you are over the age of 65 in Japan, it turns out that relations with neighbors are rather important. It's one of the few reasons why the elderly bother to get dressed up and put on makeup or whatever and get out of the house. And if you get out of the house, you use your faculties to the extent that you preserve function. Whereas if you have no reason to leave the house, you become gradually housebound and gradually bedbound. That's what the NGO people are telling us. And in a very small pilot study, we show that those people who are relocated by lottery do report, a lower fraction of them report receiving social support from other people, and a lower fraction of people who move by lottery also report, lower fraction report providing social support to others. So the relocation method matters. This is just showing what I mean by relocation. 10 days after disaster, no houses have been built. Everyone's living in the school gymnasium, and no privacy. Everyone's trying to just deal with the immediate aftermath of the disaster. This is a situation in which they were living, in which they're told, hey, you can move into a new temporary housing. Would you like to do it as a village or do it by lottery? And if you moved into a temporary housing, this is what it looks like. They look like refurbished containers, and I mean, just showing my colleagues here. But you see that in planning these temporary shelters, the designers have thought about community cohesion. These places are very important for neighbors to hang together and to look up on each other. Now, I only have baseline data, but the baseline data show that age is associated with lower IADL function. Marital status is also associated such that the widowed and never married have lower function. People with lower education have lower IADL function. IADL is instrumental activities of daily living. The more you have, the better. But in addition to individual data, we're showing at baseline some association with neighborhood variables. If you live in a neighborhood where your neighbors are socializing less often with each other, you have a significantly lower level of IADL function. The same with if you come from a neighborhood where there's low civic participation, there's less IADL function. The only thing that didn't turn up in our study so far is trust. And here's the variance parameters. We explain about 3.5% of variance across neighborhoods based upon these variables. So what we're saying is that this is a model, if you were to show it as a diagram, that if you take, let's say, functional ability at baseline, those who lived in high social capital neighborhoods probably had better function compared to those who didn't. The slope is downward sloping because for most people in life, we tend to lose function as we age. But the exogenous shock of the tsunami and earthquake set people on a different trajectory. And what we're saying is that that trajectory of loss is steeper for those people who ended up with low social capital, or who ended up coming from low cohesive neighborhoods. If your neighbors couldn't get it together and they said they didn't insist on being group relocated, they're more likely to lose function because they lost touch with each other. That's the hypothesis we're testing. And indeed, local, what's the relevance of all of this is that local NGOs and government have taken on board the lessons of social capital. They're trying to rebuild social capital through creation of organizations. This is a monthly meeting that UNUMA officials, those are the guys in the dark suits, and the volunteers are identified by the yellow vests. And then you see the residents here and there, some of the elderly residents. They gather together to troubleshoot and build social capital. We can tell this is building social capital because you can see in the background these large bottles of sake. That's what a town hall meeting looks like in Japan. Officials, you got the bridging capital between the NGOs and the municipal organizations and the local residents. When you're trying to build social capital in this region, sake is an extremely important ingredient. All right, so as a final thing, I went back in January this year, and the town is finally getting around to building permanent dwellings, not those container houses, but permanent dwellings where they're leveling the local rice fields and about to build a large apartment complex for the elderly to settle into. And my concern is that, as you can see from this diagram, it's out in the middle of nowhere, and it's going to be, I think it's going to be a disadvantage. And a lot of people have said they would rather stay in those containers than have to move out to this beautifully designed and brand new apartment complex. So it's an evolving story. I think after they become relocated, we'll go back again and measure their social capital. I'm afraid that one of the lessons from that might be that even among high social capital villages, once they move into these kinds of brand new facilities, if they're cut off from the rest of the town, they may become, again, closer to the state of where the trajectory of the low social capital resident. That's the sort of relevance of understanding social cohesion in a post-disaster context. Now, all of this I'm just sort of making up because I haven't analyzed the data yet. And if it doesn't work out this way, I will report it. But it is a story to be continued. Anyway, I try to give a sense of where research is going. I hope, in the 10 years since I last spoke with Marshall in the audience, there's been some growth in the literature, and this is where we're headed. And this is, how a country like Japan, with a high proportion of elderly population aging in place, how those kinds of countries can teach the rest of the world, including some possible lessons for a country like America, where we're also experiencing the same kind of population aging. Thank you very much. I'm very happy to take questions before our reception. I think we have time, so don't be shy. If you're a student. Yes, Dr. Copland.
Thank you for that wonderful lecture, and eager to hear the final results over the years. Can you say something about putting people of the same age in the same housing segment? Does
Yes.
a spectrum of ages help social cohesion, or limit it, and is it different culture by culture?
Yeah, no, that's a great question. So there are pluses and minuses that aren't there. So in a way, the literature on retirement says that when people retire to villages where other people of the same generation age group, they do better, because maybe having a higher concentration of people leads to changes in the way services are provided, and people can relate to each other. On the other hand, it's very important to build cross-generational linkages, and that's a kind of bridging social capital that's also important. And there's some examples which have sought to do exactly that. If Linda Fried's Experience Corps in Baltimore, rolled out to the rest of the country, is about getting retired people to volunteer as teachers' assistants in local primary schools. And she says that this is a intergenerational social capital building intervention. It's a win-win, because the retirees come out of retirement and they have something to do. They're using it, and consequently they don't lose it. And the kids, whose schools are strapped for human capital, they have these volunteers coming to read to them and teach them math, so their grades go up. So she says it's a win-win, and that's a kind of intergenerational bridging social capital. But so I think there's evidence on both sides. It seems important to build bridges so that we don't end up in a sort of a age or any other kind of segregated society. But on the other hand, there's some benefits also to moving to communities where there's lots of other retired people who can understand the service provision needs as well. Yes.
Thank you so much for your presentation. If you could clarify, would you say that the social capital, the type of social capital that you're talking about here, is more bonding social capital?
Yes.
And second, as it relates to sort of bridging and linking social capital, as we think about communities and organizations within those communities, the idea with bridging and linking social capital being connecting
Yes.
people that may not normally have access to institutions and resources being important.
Yes.
Can you say a little bit about the work that's going on, or any work that you've done that helps us understand that better, the extent to which groups of people that don't typically have access to those resources,
Right.
What's the evidence around the bridging social
Yes.
capital, linking social capital piece?
So what little evidence we do have suggests bridging is extremely important. Just to get over it, bonding is this idea of resources that are shared between members of a network or community who are rather similar to each other with respect to characteristics like social class, race, religion, whatever. And bridging is those kinds of capital, the connections that allow you to literally bridge those kinds of gaps. And I mentioned earlier about the potential dark side of social capital. When the dark side has been discovered, it's often because there's very strong bonding capital, but not enough bridging. So you can have very tightly knit communities that don't promote the health of the residents in them because they pull the norm, down leveling of norms, intolerance of diversity, restrictions on freedom, all the things that we associate with communities that are too cohesive because they're too similar to each other. People are too similar. So in those cases, the kind of capital we're looking for is ones that allow people to bridge socioeconomic hierarchy. And in organizational terms, that would, for example, the last example I gave the monthly meetings between NGO groups and government officials and residents is kind of bridging capital, because it's allowing the residents to bridge the hierarchy of power to give voice directly to the municipal authorities, who could then turn around and provide residents with better resources. So it's that kind of capital that we think would be most helpful for health promotion. And a few examples we have of that, that they're quite powerful. I was talking to you earlier about these prevention of ethnic conflict in India. There are many cities and towns in India which have more high or low levels of ethnic conflict, even though they seem to have the same proportion of Muslim and Indian residents. And according to Ashutosh Varshney, who studied this, he finds that the cities that are most effective at quelling violence are those that have a vibrant civic community in which are integrated with respect to Muslim and Hindu membership. When they are integrated, that is, they bridge this religious divide, they're much better at quelling violence before they get out of hand. And so I think there are lots of examples of bridging capital as being the important thing to try to build in some way. We don't. It's not social capital intervention is not about some building cohesion no matter what type. You have to be a bit selective about understanding what is it that you're trying to build or optimize. Dr. Jones, yes, I didn't see you.
It's great to see you again. It's great to hear you again. And I wanted to build off of that last question, because it strikes me that what we need to do, at least in this society, is have people break through bubbles.
Yes.
That we're all in our little social capital bubbles, and we go to our schools, and our kids' schools and our churches and our jobs and like that, and we don't have a very good sense that people just across town are just as smart, generous, funny, kind, whatever, intelligent as we are, but have very different local situations. So that bridging capital that you've just brought up and that you're talking about is a key strategic intervention, perhaps, so that we can all understand that there but for the grace of God go I, or we are all in this together, that kind of thing. Are there any policy suggestions that you have, or anything that you're aware of, where people are, you say there's the experimental evidence or the observational evidence that people with more bridging capital do better, but what can we do?
Right.
Okay.
Yeah. So thank you, Kamara. The policy question to that, the policy answer to that is in the context of U.S. Social capital, surely desegregation. Isn't it? Desegregation policies, desegregation of our schools, of our neighborhoods, that's one bridge, link, that is one avenue to building, bridging capital, I think. So it's a sort of a high order policy thing. I mean, of course, social capital, you can move up and down the levels of intervention, because you can all practice bridging capital in our own lives to some extent, by volunteering and building communities from the ground. But I think the high level policy question is sort of this desegregation, is going to be it's a structural intervention that you're going to have to do to encourage social capital. In the context of Japan, we have published a study of bridging capital, but in Japan, because it's rather ethnically homogeneous, the main power differential occurs between the sexes, is between men and women, and we found that women who said they belonged to associations which were heterogeneous with respect to sex, that they belonged to groups where there fair number them weren't just segregated to other women's groups. There were also men participating. They had it had a much stronger impact on their health than bonding social capital, and we don't find that for the Japanese men. So it's rather interesting that. So I think it is. You have to understand the social context of each society. Where are the gaps in power and differentials, and are there appropriate interventions that could bridge that, allow people to reach across the hierarchy and to bridge that gap.
Thank you. We have a small token of appreciation for Dr. Kawachi for being the inaugural speaker for the Kreuter Katz lecture.
Thank you very much.
Please, if you'd like to stay. Please join us for a light reception afterwards. We'll have a chance to talk to Dr. Kawachi and to our honored guests, Marshall Kreuter and Martha Katz, who I'd like to have stand now. They refused to come up to the podium. We gave them plenty of opportunities. We would keep the microphone away from Marshall, but we would offer it to Martha. But please, Martha and Marshall, please stand so you can be acknowledged. Let me thank you all for coming today, and thank those of you who watched on streaming video or participated online. We hope that Dr. Kawachi's comments will be a catalyst for further discussion and change about the importance of risk that's not only measured by behavior, as we tend to, but also by how we treat one another. I want to thank the Healthcare Georgia Foundation for their support for this event. We couldn't have started it off, the first inaugural event, more successfully than today, and we look forward to the future years. I'd like to also thank, as you know, events like this don't happen spontaneously. They happen through a lot of hard work of people who don't get on the podium. But I'd like to thank the Planning Committee, Julie Smith, Sanday Abernathy, Francis Marine, and Ellie Faustino, who are around the audience, so thank them for all their hard work. And so, again, thank you for coming. There's plenty of time to socialize. You'll have a chance to meet the speakers and the honored guests, and look forward to next year's event. Thank you.